Hello, how's it going, my platypi? Welcome to LRTIs, or lower respiratory tract infections. And let's get into it. So I talked about the ERTs before, and I told you that sort of ends at the larynx, and the lower respiratory tract is further down. So that's from the trachea to the bronchi to the bronchioles to the alveoli, really. And there are a lot of different conditions that sort of fall into this category. We can break it up into acute and chronic, just to make it simple for us. Now, such as croup in the ERT spectrum, a couple of them also affect the upper respiratory tract. The first of which being whooping cough, which we shall start off with. All right, so a lot of info here, but let's take it step by step, right? The organism's always going to be Bordetella pertussis, since that is characteristic of whooping cough. Whooping cough is called whooping cough because in one of the phases, we have a whoop, an inspiratory gasp of air as one of the symptoms. So let's go through the phases. We have an incubation period of 1 to 3 weeks, so it's a pretty long time. We have a catarrhal phase. If you search up what a catarrh is, I believe that refers to upper respiratory tract symptoms such as a runny nose and a cough. So it's generally that sort of stuff, hence the name catarrhal. Because of the infectious, disgusting nature of it, it is the most infectious phase in the whooping cough sort of disease progression. Paroxysmal phase involves severe episodic coughing, which is called paroxysms, and it lasts 2 to 4 weeks, which gets so bad it can cause vomiting. And in this phase, we see the whooping. The next phase is the convalescent phase, which is the phase after the infection is being sort of clearing, it's gradual recovery, and slowly less persistent paroxysms. Yeah. Diagnosis is through a per-nasal swab. Obviously, it kind of makes sense that if you want to do a nasal swab, you want to do it when there's a lot of stuff there, so that would be an early catarrhal stage. Treatment involves antibiotics and supportive care. Antibiotics also most successful in the catarrhal phase, so you really want to catch this early. Supportive care is to avoid complications, really. Prevention involves the DTaP vaccine and also prophylaxis for close contacts. Okay, influenza, another acute condition. So, influenza, I don't need to talk to you about the symptoms of it, but let's talk about sort of how it enters the body or enters the cells of the body and the proteins involved. So you might have heard of the words H1N1, naming some of the flus that we've seen in history. And the H refers to hemagglutinin and N refers to neuraminidase. The hemagglutinin refers to the protein that permits cell binding and entry. So that's that's the protein on the viral surface, I believe, which allows it to endocytose and enter the cells. Neuraminidase is the one that permits release of viruses from infected cells. And the mutations to them leads to different strands, which can be named and are characteristic of influenza viruses. There's a lot of complications that can occur. You can have pneumonia, as well as a secondary bacterial infection. You can have myositis, inflammation of muscles, myocarditis, and neurological symptoms or syndromes. One of them being Guillain-Barré syndrome, which is an autoimmune attack on the peripheral nervous system, and encephalitis, which is brain inflammation. So a lot of muscle stuff and neurological stuff. I believe the list goes on. But talking about diagnosis, mostly clinical, and it is especially at higher risk of being influenza, obviously in season, when GPs are seeing a lot of presentations like this. Investigations include serology, respiratory set specimens, and viral culture / PCR. Treatment involves attacking or targeting like this stuff that we talked about here. So apart from the symptomatic treatment, which is anti-fever and antihistamines, we can inhibit the uncoding step of influenza. Okay, we didn't really talk about this, but once hemagglutinin allows the virus to enter the cell, it can cause, well, not cause, but there's another step which involves uncoding of the virus, which permits injection of the viral DNA or RNA into the cell. And this uncoding step can be stopped by these two drugs, amantadine and rimantadine. Inhibitors of neuraminidase, on the other hand, are oseltamivir and zanamivir. And we've also got a seasonal flu vaccine, which is pretty cool and so peaceful. Okay, so moving on to sort of jumping over to chronic. Let's talk about TB for a bit. Characteristically, Mycobacterium tuberculosis. Now, there is another sort of specific way that TB presents, which is traced back to the specific way that TB infects. It's an intracellular pathogen that enters cells, and it prevents the fusion of phagosomes and lysosomes. So typically, a mode of immune defense is phagocytosing pathogens and fusing with lysosomes, which we know are enzymes that break down stuff. So once it fuses with that, it sort of throws the lysosome at the I think it's kind of like a vesicle that the virus is trapped inside the phagosome or the phagocytic cell. And once they fuse, then the enzymes break down, obviously, the pathogen. But if you prevent that fusion, it prevents the killing of the pathogens and prevents literally the function of alveolar macrophages. And that's how it survives and evades the immune defenses. Okay, so another thing is also, when it comes to cell-mediated immune response, the cell-mediated immune response, we can see a granuloma formation. A granuloma refers to sort of this structure here, where immune cells cordon off the pathogen. Yeah, they sort of surround it and stop it from spreading, which leads to little lesions in the lung that look like that throughout the body, throughout the lung. Prevents it from spreading, but also it's not going to die because it's sneaky and hides, which means it probably goes latent. Let's talk about primary TB and secondary TB. So primary TB involves encountering the infection for the first time. So we've got a bunch of little lesions. We call the clusters of tuberculosis infected stuff tubercles, which are nodules that contain caseous necrosis. So that's a type of necrosis, which means the cells already died and they're sort of just in the lung there. The primary complex, which are these tubercles, are called gonfoci for plural. They may heal spontaneously or persist for a lifetime. Most of the time, it's just asymptomatic. No one really knows they're there. Fibrosis and calcification, easy peasy. But if you're immunodeficient, it can cause spread, and we'll come to a secondary TB. Okay, fun fact, it spreads to the lung apex, which is the top, because you have the highest VQ ratio there. And TB is aerobic. Don't worry if you don't know what VQ is yet, but once you know that, come back to this and it will make a lot of sense. It also causes an enlargement of lymph nodes in the area. Okay, secondary TB, which is reactivation of dormant bacteria due to a period of immunodeficiency. So this results in further spread, right? We can have spread in different ways. So in one way of spread is the tubercle breaks into the bronchi, which breaks to other parts of the lungs. And this causes consolidation and cavitation, especially in the apex again, so unlucky apex. But another way is it enters the bloodstream and lymphatics and leads to systemic spread. So this is miliary TB. So we see millet seed-sized lesions, which is what we call it, miliary TB, on chest x-rays and other parts of the body, so in other bones even. So pulmonary miliary is when you see it in the lungs, and systemic miliary is in other parts of the body. Symptoms. So this is a lot worse than primary TB. Primary TB, I said, was mostly asymptomatic, yeah? This involves B symptoms, which is a cluster of weight loss, night sweats, and fever, chills, malaise, loss of appetite, even bloody sputum is pretty characteristic, especially in Monash land. Okay, so diagnosis, there's a bunch of different stuff that we can use. Focus on the stuff that's bolder, I guess. Mentotuberculin test or an interferon gamma release assay for latent TB. Oh, well, it detects obviously present TB as well, but latent TB as well. We can do a acid-fast test with a Zeal-Nielsen stain, which is the specific stain that's used on the sputum. We can perform a culture, however, it's super slow growing, so be careful of that. But you want to grow it and attack it with antibiotics to figure out which one works if you suspect antibiotic resistance, because otherwise your treatment's not going to be super effective. But as for treatment, we have the RIPE acronym. We should know this: rifampicin, isoniazid, pyrazinamide, and ethambutol. Pyrazinamide. Yeah. Okay. Let's move on to back to acute. So we're talking about acute bronchitis. Okay, bronchitis. There is a cough and thick mucus. Usually viral, but can be secondary infections. Can be pneumonia, and can also lead to secondary infections. Sputum culture if you suspect that stuff, but otherwise fairly straightforward. Okay, chronic bronchitis, if already present, can exacerbate acutely and can sort of look like acute bronchitis. However, we've got to be careful with the definition of chronic bronchitis, because we can elicit this on history taking and make sure that this is what's going on instead of an acute case. So chronic bronchitis refers to a cough with excessive mucus secretion, so going on for more than 3 months. There's no explainable cause of no other possible diagnosis causing the cough, and is triggered by viral causes or by allergens. Treatment they're probably going to be on is bronchodilators and maybe antibiotics to avoid secondary infection. But yeah. Acute bronchiolitis. So this is one step down from the bronchi to the bronchioles and can lead to obstruction of them, leading to wheezing and respiratory distress. Fever and cold-like symptoms also. Note that this is especially for children. Organism is 75% RSV, respiratory syncytial virus, and 25% these other two things. We can do a nasopharyngeal aspirate, which is basically just getting fluid, I believe. Supportive treatment, but if it's RSV and if it's severe, then we can think about nebulized ribavirin, which is an antiviral, which is helpful for us if it's especially bad. Okay, I mentioned RSV super quickly. We saw it in a lot of things, and we see it in pneumonia as well. We see it in otitis media, and we see it in bronchiolitis. again, ribavirin. There's also a prophylactic intramuscular injection of a monoclonal antibody, but there's no vaccine to it. Pneumonia. Infectious agent. There's three main types: typical, atypical, and viral. Okay. Yeah, so I talk about these are classifications of the presentation on a chest x-ray, really. So we can have interstitial findings, we can have lobar and segmental findings. I think that's an easy way to think about it. But typical versus atypical, and I said that was viral as well. But typical versus atypical, we've got a lot of different pathogens for typical, but for atypical, it's mostly Mycoplasma pneumoniae. For all ages, strep pneumoniae, COPD elderly alcoholics have their own cluster of stuff. IV drug users and elderly have Staph aureus, cystic fibrosis, very characteristically Pseudomonas aeruginosa. Both have a fever. However, atypical has a dry cough and watery mucopurulent sputum. In typical, there's definitely evidence of consolidation on physical exam, as we have a lot of other things that we see as well, shortness of breath, abrupt onset. But in atypical, there's few abnormalities on physical exam, but on the chest x-ray, it looks like that. So there is, there appears impressive infiltrates, but it is sort of diffused and spread over the entire lung, which is also what we see in viral infections. As for the chest x-ray on typical, it's very key, it's very distinct, has a specific area of consolidation. And yeah. Okay, let's talk about lung abscesses. I talked to you about what an abscess is, which was essentially a pus-filled area. And a lung abscess is just a pus-filled producing infection of the lung. Okay. These abscesses can be polymicrobial or monomicrobial. Polymicrobial abscesses typically form on aspiration of foreign stuff into your lung. So if you essentially have stuff that goes into your lung instead of swallowing, that can lead to a polymicrobial abscess. It can be pretty serious. So you can have, And one way that you can aspire foreign stuff is if you have altered consciousness. And yet, because of that, you have a diminished gag or cough reflex. So you aspire respiratory or gastric secretions. We can have septic embolization from sort of the heart, and also general bacteremia, which goes and deposits in the lung and causes lung abscesses. Yeah. Empyema. So this is infection of the pleural space. Can be Staph aureus, gram-negative, anaerobes, can be polymicrobial. You want to aspire the pleural fluid to really find out, and antibiotics and drain it, and a chest x-ray. Cystic fibrosis. So you probably have heard of this before. CFTR mutation causing abnormally thick mucus. Affects a lot of different systems, but when we're talking about the lungs, it leads to chronic colonization, and it's almost impossible to eradicate these infections of it, leading to chronic lung damage. So the organisms are Staph aureus and Pseudomonas aeruginosa predominantly, and the change of age. So we see Staph aureus being more predominant in teenagers and younger, and Pseudomonas aeruginosa are more for adults and older. You have a lot of different types of treatment for that. And I think that concludes my presentation. Thanks for watching. like, and subscribe.